My topic is controversies to consensus in the management of hypertension. As we all know, hypertension is a silent killer. It's a reversible, readily identifiable risk factor for major of the diseases like ischemic heart disease, myocardial infarction, stroke, atrial fibrillation, aortic dissection, peripheral arterial diseases as well. And it's the cause of 2/3 of stroke and 50% of the ischemic heart diseases worldwide. And the asymptomatic nature of hypertension delays the diagnosis. However, a knowledgeable physician with frequent follow-ups can readily diagnose the hypertension and definitely treat it. Moving on to my topic, controversies. These are the two most recent controversies and innovations, and I swear it must have been given hypertension to many. My today's talk, mainly Indian scenario of hypertension, the actual blood pressure measurement, how we should measure the blood pressure, and the role of ambulatory blood pressure monitoring, guidelines of hypertension, the similarities and dissimilarities between them, the recent trials which have given rise to the implications with mainly SPRINT and HOPE-3. HOPE-3 is right now in the limelight. Then special cases, mainly diabetes and CKD, and chronopharmacology, means the timing of the drug, which time you should give the drug mainly. In Indian scenario, it's prevalent around 30% of the people in India are suffering right now from hypertension. Rural and urban are nearing equal each other. The trends has increased over the past 50 years, and mainly urban population is suffering rather than the rural populations, maybe because of the lifestyle. And it's not only the prevalence, but are we aware of the hypertension status? Or suppose the patient is aware or the family doctor is aware, is he being getting treated properly? And how much of them are getting BP under control? If you look at the figures, it's 20% in urban and only 10% in rural, those who are getting blood pressure under control. So despite all the efforts, the level of awareness about BP is still low in India. The blood pressure measurement, I'm also sorry to say, not only physicians, even everybody, each of us are doing this in a sloppiest, most probably, I'm not sure, some people might be doing very accurately, but most of us do this in a sloppiest manner. Ideally, we should take 3 readings, each 2 to 3 minutes apart. We should ask the person to be refrain from smoking or drinking tea or coffee or exercise for at least 30 minutes before measuring the BP. And we should allow the patient to sit for at least 5 minutes in a quiet room before beginning the BP measurement, and more preferably in a recliner. And it should be done in a preferably sitting or supine position. Arms should be fully bared and supported at the level of heart, and measure the blood pressure in both the arms and use the higher one as the 2 readings. The major techniques and most of the important is the cuff size and the rest. And if we take the 3 readings, usually the first reading is higher. So, and that gives us the alerting response that he might have hypertension. So if we discard the first and take the average of the two, 18 to 34% of the hypertensive may be normotensive actually. Yeah. The total procedure requires 8 to 11 minutes. This is the recommended size of cuff for blood pressure measurement. It should cover around 80% of the arm circumference lengthwise and 40% widthwise. And the ambulatory blood pressure monitoring is very important because it has right now, it's showing if you search in the website, more than 10,000 publications worldwide is about the ambulatory blood pressure monitoring, and it has started way back in 1978. about the ambulatory blood pressure monitoring, and most probably because of white coat hypertension is the most important thing. And other indications I will tell you later on. It is actually measures the 24-hour average BP monitoring for day, night and morning while the patient conducts his normal daily life. And it correlates more closely with the hypertension related organ damage and its changes by the treatment than does the office BP measurement. And we can identify the persons who are non-dippers. Non-dippers means at the night time usually the blood pressure dips, but patients who are there is no dip in the night time, and those are actually more risk for cardiovascular morbidity and mortality. The other indications are borderline hypertension, isolated systolic hypertension in elderly, nocturnal blood pressure, resistant hypertension, hypertension of pregnancy, hypotensive symptoms. The European Society recommends the normal in awake is less than 135 by 85, at asleep less than 120 by 70, and an average of 24 hours is less than 130 by 80. And how to interpret it is you should take at least readings in an interval of 30 minutes minimum, or better it should be in 15 to 20 minutes of interval, a minimum of 14 minutes while 14 readings while you are awake and 7 readings while you are asleep, so that you calculate the average of the figure, and then you actually get the daytime, nighttime and average readings. The recent guidelines, Joint National Committee JNC 8, European Society and American Society, all of them telling about the threshold of drug treatment more than 140 by 90, but recently they have added the age limit. JNC 7 had no limitation, no differences in age. JNC 8 tells 140 by 90 less than 60 and more than equal to 60, 150 by 90. European Society is all the same, is telling 160 more than in elderly, and American also 140 by 90, there are some more elderly, is less than 80 years. But beta blockers, which were previously in the first line of treatment, are now only the European Society, and Indian Society still considers it as first line treatment, beta blockers. Previously it was not. And when to start more than one drug, the committees are telling it's more than around 160 by 100. However, the Indian hypertension guidelines still consider the beta blocker as the first line management. In younger people, they start with A or B. A means ACE inhibitor, ARB. B is beta blocker. C is calcium channel blocker. D is diuretics. This all of you know. In the first step, ACE inhibitor, ARB or beta blockers in younger, calcium channel diuretic in the older. In the second step, diuretic or calcium, either of these combination. And then in the third step, diuretic is a must. Either of ACE inhibitor, ARB or beta blocker plus calcium channel blocker plus diuretic. Diuretic is a must in the third stage. If you are adding a third drug, then diuretic is a must. And before stamping as resistant hypertension, the resistant hypertension definition is 3 drugs, at least 3 drugs with optimum doses, and that must contain a diuretic. So if the patient has resistant hypertension, either addition of alpha blocker or spironolactone or other diuretics. And the beta blockers which were Indian hypertension guidelines consider is the newer beta blockers, which are the vasodilator beta blockers, mainly the nebivolol. And what about the fixed dose combination? Because in India, the pill burden, the cost of medicines leads to non-adherence and non-compliance. So the combination therapy is definitely gaining ground, and much of the patients are requiring more than 2 drugs. So Indian guidelines use of fixed dose combinations should be considered. And as such, along with hypertension, other risk factors for CVD, just like dyslipidemia, obesity and diabetes, also tend to cluster. So a combination such as polypill might be a useful tool. Even Cadila have a polycap. There contains all the 5 drugs ACE inhibitor that contains statin as well, ACE inhibitor, statin, diabetic, beta blockers. So something is better than nothing. Suppose the patient don't take anything, so at least we can take at least single medicine. And some recent ongoing trials are there, tips 3, which would provide more evidence on the role of polypills. And Indian guidelines says that this I've told that beta blockers are still used in the young hypertensives. And about the diuretic choice, chlorothalidone is not only in Indian guidelines, it's outside also. Chlorothalidone is now available and shown to be better than hydrochlorothiazide for its usages. Again, coming to the beta blockers, why they are not used now? Because of the two major trials, life study and Ascot BPLA. Life study was versus losartan, and Ascot BPLA was against the calcium channel blocker amlodipine. So both of those show that the all-cause mortality was significant with either CCB or ARB rather than beta blocker. But the beta blocker that was used was atenolol in both the studies. So the newer beta blockers, which have which have less of limitations of the as of atenolol. So it may be timely for treatment guidelines to recommend third generation vasodilator beta blockers, maybe a first line. That is shown in the Asia. The ESA people also still feel that the third generation nebivolol is still as a first line option. Coming to the recent trials, the SPRINT and HOPE-3, what does that tell? The SPRINT trial is mainly was done in non-diabetics, and its role was to treat intensive treatment and then see about the primary outcome. Intensive means less than 120, not just bringing it down to 140. So when they did the intensive management, they found that there is 25% lower risk of the primary outcome. But on the contrary, when they have reduced it to intensive care, then along with the blood pressure fall, there was acute kidney injury or acute renal failure also there. It was p-value was less than 0.01. It was significant, but does it represent a harmless hemodynamic effect or more serious renal injury is still unclear. So to conclude about SPRINT trial, the treatment effect is similar in all 6 groups, and the benefit of more intensive BP lowering still exceeded the potentiality of harm. And if the SPRINT is applied without attention to proper BP measurement, in the SPRINT measurement they have done the measurement in the rooms without a clinician, with automated machines. So if it was done without attention to proper BP measurement and substantial overtreatment, they have a higher rate of adverse events. And would the guidelines will change after systolic blood pressure less than 120? The average achieved systolic BP in the intensive treatment group was 121.5, which was remained higher than 120, and this likely represents the judicious balancing by treating clinicians who try to approximate the 120 mm goal while avoiding the side effects. So what they found to conclude the SPRINT thing, they found that chlorothalidone at the doses of 12.5 to 25 was the thiazide type of diuretic of choice. Amlodipine was CCB of choice, and beta blockers they have considered to be less effective in preventing CVD events except in those with coronary artery disease. And the most important HOPE-3 trial, and as of all of us know about the first HOPE trial, the ACE inhibitor ramipril came only after HOPE-1 trial, which has showed that 10 mg per day of ramipril reduces the CV risk at significantly. After that only ACE inhibitor come into limelight. But the HOPE-3 trial, this hypothesized this patient, they took patients of intermediate CV risk with normal or lower BP. So do the antihypertensives reduce the CV events in these cases? They have taken ARB candesartan and diuretic hydrochlorothiazide for that. And what they have found, there is no incidence changes in no significant differences in the outcomes or all-cause mortality. In the HOPE 3 subgroup analysis, they have found that this 143.5, when the blood pressure was more than 143.5, then only there is the candesartan and this group is better. Otherwise, in other two groups, when it was the blood pressure is not more than 140, there is no difference in all-cause mortality. In subgroup of upper third only, the active treatment has nominally significant lower rates. HOPE 3 also emphasized on the BP measurement protocol. This is the same thing which I have discussed. They have also used the automatic Android or oscillometric manometers also, the Omron automatic blood pressure monitor, and special attention to the proper BP measurement. And what they finally commented, that it's not that the lower is the better, and the data compatible with the hypothesis that treating persons without CVD who have a systolic blood pressure above 140 is beneficial. But treatment would not be of benefit and even harmful with the persons who have lower systolic blood pressure levels. In some special cases, in the diabetics accord BP trial, they have classified two groups, less than 140 and less than 120, and they have also found that there is not much of differences of this less than 120 or 140. More than 140 is okay, but less than 140 there is not much of difference, no intensive differences in fatal events. According to this KDIGO study, in non-diabetic with CKD or diabetic adults with CKD or with kidney non-diabetic with CKD or diabetic with CKD, the recommendation is less than 140/90 if there is no albuminuria, and if albuminuria or kidney transplant patients, the recommendation is less than 130/80, and elderly people with CKD less than 140/90. So if albuminuria less than 130/80 is the target. It's around the same, the JNC8, European and American, less than 140/90, we can, in short, we can keep it less than 140/90, and with albuminuria less than 130/80. In women, mainly methyl dopa, labetalol, nifedipine are the preferential drugs in pregnancy, and with women with childbearing potential, we should avoid RAS blockers, ACE inhibitor or ARBs. And I think this is one of the most important things, the combination of classes. The recommendation of ACE inhibitor and ARB is actually contraindication. The on-target trial has clearly told that we should not use ACE inhibitor and ARB both in a combination. Rather, other combinations, CCB ARB, CCB ACE inhibitor, CCB diuretics, you can use. Even ACE inhibitor diuretics, ACE inhibitor CCBs, that can also be used. But the use of ACE inhibitor and ARB should not be used. About chronopharmacology, the dosing schedule, the various trials have shown about the evening dosing. The MAPEC trial, they have done the 48-hour ambulatory blood pressure monitoring, and that showed that with evening dosing, there is lower risk of CV events. So the other Cochrane review, they have also shown the same thing, evening versus morning. They found the better BP control with bedtime dosing. And other recent trials are ongoing, the TIME and HYGEA trial, which are about to complete. They are also trying to get it done with which one is better, morning or evening. So I conclude my talk with, to conclude, hypertension still remains a public health importance in India. Methodology to measure accurate BP should be given the due importance. Ambulatory blood pressure monitoring, definite useful. Although recent trials have provided useful information for lowering BP further, usual goals of BP should be followed. BP goals can be lowered further in some special population. Choice of drugs for controlling BP should be individualized. Till more data emerge, evening dosing of antihypertensive can be advised, and it's high time that India should have their own CV outcome trials. Thanks everyone for your patience, as the Indians are still patiently waiting.